Thank you, everybody, for having me here. My talk today is about children with neurodevelopmental delays in humanitarian emergencies. And this talk is in collaboration with some colleagues with MSF, Marlene Goodfriend and Harriet Roggeveen from the Holland office, and with Daniel Garcia from Barcelona. Before I get started, I want to maybe tell you a little bit about myself and how I got to be involved in this meeting, which my topic is a little bit out of the a little different than what has been presented so far. I'm a developmental behavioral pediatrician, which means I take care of children with neurodevelopmental delays, including diagnostics and management and treatment, and overviewing their management. I'm originally from Palestine, and as a little boy, my family was forced to move to Jordan. So there's it wasn't as dramatic as the current refugee situations that we see, but it was actually a relevant event in my life that was quite transformative for me. I grew up in Jordan and pursued subsequently moved to the US to pursue my medical training, and I specialized in developmental and behavioral pediatrics at Boston Children's Hospital. Eventually, I made it. I'm heading back slowly east, and I currently live and work in London. But I keep going back and forth to do some work in the Middle East, particularly in Jordan, where I still have a lot of family. So, when I was going. This slide says that happiness is coming back home from a long trip, and this is something that was always important for me, to go home and see family. And this on top is an idyllic picture of Amman in the evening, maybe somewhat sanitized. But the reality of actually Jordan and in general the Middle East or the Arab world these days is one of immense sadness. Every time I go back or watch the news, the amount of suffering that is out there is getting worse and worse. And for me, as a developmental pediatrician who takes care of children with neurodevelopmental disorders, my first thought is about children, and particularly children who have some form of disability, and how are they faring in this horrible humanitarian crisis that has been going on in this region for years. So who are these children? The children with neurodevelopmental disorders, a rough estimate is about 10 to 20% of children have some form of a neurodevelopmental disorder. And this is an estimate from Western countries, and getting more accurate estimates from the developing world is challenging for a lot of reasons that we can discuss at length later. But in general, these are children who have delays in appropriate development in speech, motor, cognitive, and social domains of development. These include communication disorders, autism, intellectual delays or disabilities, learning difficulties, and mobility problems. And obviously, as we've talked a little bit throughout this conference, there's multiple causality from some of the things that you guys encounter a lot: malnutrition, birth asphyxia, poor perinatal care, to other more subtle contributions, such as genetic disorders, for example. And the other thing that's important to know obviously in caring for these children, which is what I do on a day-to-day basis in my regular job, is identifying and trying to provide what they need. And some of it is extremely basic: a nurturing and a safe environment, appropriate medical or physical health, good nutrition, and on top of that, appropriate developmental interventions. And many of these developmental interventions happen to be be parent training, just educating the parents of what they can do to help their children. There's a lot of therapies, and these therapies, as noted in, have been relatively well developed in high-resource countries in terms of what can be done, and that they're showing effectiveness in improving the outcome of these children. And what's also very important is the timing of when we give these therapies. And the importance of timing is that giving early intervention or therapies for children with developmental disorders or delayed in the first 3 to 5 years of life will make a huge impact in terms of their overall cognitive and function throughout the lifespan. And this is a very sort of like slide that shows it nicely with if you look to the left-hand side is the young ages, and the curve there shows that the most effective interventions and the least effort that you need to do would be in the first 3 to 5 years of life. And that has been demonstrated through multiple studies showing that it minimizes morbidity, it reduces family and community stress, and it reduces the long-time financial costs. So financially, it's every $1 spent on early childhood services will save $8 in the future, and this is from studies in the U.S. I have 4 minutes? Okay. And the other very important thing is the actual implication to the human being. This can make, providing timely interventions can make the difference between a child with autism, for example, learning to talk. And can you imagine how that would, the impact of a child being able to say a few simple words to request or to express their needs versus not being ever able to do that as a 20 or a 30 or a 40-year-old person. Similarly, being able to go to the toilet on their own. So it has really huge implications. So my main concern and the issue with timing is what happens to these children in humanitarian emergencies. And this is what I call the perfect storm, which is an obvious reference to the book. But it basically tells you, like, everything bad that can happen is happening in this situation of a humanitarian emergency. These children, everything that they need for appropriate development, the safety and the support, the availability of appropriate parents, and the availability of professionals to do interventions is actually disrupted and not there. So the question then that comes up is, can the humanitarian community address this problem? And there's actually, addressing this problem is, there's some clear ideas of how one begins to do it. I think it's similar to a lot of the other things that we've talked about. How do you apply what's been learned in high resource setting to the lower resource setting? And the problems include, or the things that are needed are identifying those children, so that would require an appropriate screening program to look for them. And then appropriate interventions that can be feasible, low cost, not necessarily provided by specialists, and that give a high yield. And fortunately, we are at a time right now where there's actually several paradigms or models being developed worldwide to transfer some of the knowledge that we have from high resource setting to low resource setting. Some of them led by the WHO, and some of them are led by other groups, and we can discuss those at length. The principles are actually very simple, and I'm showing here just one example of a screening tool where just basically sitting down with the parents at either a healthcare visit, either the healthcare provider or a nurse or community worker, and asking, how does your child talk? How does your child walk? Do you worry that your child is having a certain behavioral problem? So, and then subsequent, obviously, the next level of discussion can be is, can this be integrated into, can these kinds of interventions and be integrated into the MSF setting? And I think we should always be in the mindset that development does not wait. We have this very crucial window of between 0 to 3 or 0 to 5 years. And if you are unlucky enough that this window happens during the time of a humanitarian emergency, I don't think it's fair for this child to actually lose out. So can we actually identify these children in MSF settings? Can we pilot a screening study? Can we identify resources of interventions? Or does it involve working much more collaboratively with other agencies that may be responsible more for education or early intervention? And I think we have to keep in mind as pediatric providers that our vision for the health of children is actually really long-term and goes across the lifespan, so that this type of a happy family, this is a picture of a Syrian refugee family that from a newspaper in that were featured in a newspaper in the UK, but it just shows that look how happy these children and the families are. And I think this, for me as a pediatrician, and particularly as a developmental pediatrician, this should be the long-term or the big vision of the purpose of the care that we provide to children. Thank you very much for your time, and I'll answer any questions.
Thank you very much. Thank you very much, Ramzi. I'll allow myself the first question, yes, if I may. There has always been a dilemma, particularly in developmental and humanitarian emergencies, about diagnosing what we cannot treat.
Yeah.
And that goes over many diseases, starting from HIV and ending in here. Is it, do you see a way whereby MSF, with a sometimes short and sometimes basic interventions, capable of doing something that makes a difference if they identify the children?
I mean, I think the level of treatment is there's curing and then there's treating. And I think these disorders are actually often obviously very chronic. But there's a lot of interventions that can be done that can make really meaningful impact into the lives of children. I mean, can you imagine just something as simple as helping someone become toilet trained? You know, can you imagine sort of like the downstream effects of that in a humanitarian setting or on the life of the family? But in general, also communication disorders. There's already well-known protocols, for example, in the West of how to treat those children. And there's actually, like I mentioned, there's two current at least two current models that are being piloted in developing countries, one of them by the WHO, to actually provide that kind of intervention in low-resource setting. And it's primarily utilizing the parents. So utilizing the parents and particularly the mothers to treat their children. So the challenge now, I think, is to go, from the safe and secure low-resource setting to the humanitarian setting. But I think we really owe it to these children to at least start thinking about it, because I don't think it's a big leap or a stretch to think that we can go that way. And the other thing about this is that it's relatively cheap, because it's an intervention provided by community health workers, and then the parents implement it, and there's no technology, So I think it can be, it has a great potential for being effective.
Thank you very much.